Hi, my name is Brittany Muniz. I'm a graduate nursing student at West Texas A&M University. Today I'm going to be doing a head-to-toe assessment on a 33-year-old male. He's come in today to have a checkup. We have already reviewed all of his past medical history, his surgical history, his family history. We reviewed his allergies, which he has no known drug or food allergies. He is up to date on all of his immunizations, including his flu shot and his tetanus. We've already obtained his vital signs, got his height and weight. We've tested cranial nerve number 2, which is the optic nerve with the Snellen chart. Everything was good there. I've washed my hands, and now we're going to proceed with the head-to-toe exam. First off, I'm just going to check the hair distribution on his head, just making sure that it's nice and even. Check the texture. I'm also going to feel on the skull just to make sure that there's no nodules or tenderness. Throughout the exam, I'm going to go ahead and assess his skin color, the hair distribution, check the fingernails and toenails for any clubbing or any signs of cyanosis. I'm going to palpate the frontal and maxillary sinuses, just checking for any tenderness. While we're here, we're going to go ahead and check his femoral pulses, make sure that they're 2+ and equal, and they are. We're going to go ahead and move down to his femoral mandibular joint. I'm going to have the patient open his mouth, close it, move your jaw side to side, just checking for any clicking or tenderness. Now we're going to go ahead and note that the nose and the mouth are midline, the eyes and ears are symmetrical. We're going to go ahead and do the assessment on the eyes. First, we're going to go ahead and check the conjunctiva, just looking to make sure that it's pink, and the sclerella to make sure that it's white, that there's no yellowing noted. Next, we're going to go ahead and check the pupillary response for direct and consensual. So if you'll just look straight ahead, direct and consensual, direct and consensual. Perfect. Now we're going to move on to accommodation. I'm just going to have you look at the pen light and then the wall. Pen light, the wall, pen light, and then the wall. Perfect. We're going to go ahead now and check cranial nerves number 3, 4, and 6, the oculomotor nerve, the trochlear nerve, and the abducens. So if you can just follow this pen light. We're just looking for any jerking of the eyes or nystagmus. That looks good. Next, we're going to test the trigeminal nerve, which is cranial nerve number 5. If you can close your eyes and tell me if you feel sharp or dull.
Sharp, dull, sharp, dull, sharp, dull.
Perfect. Next, we're going to move on to the ears. I'm just going to check the auricles, just making sure that there is no nodules in there, no soreness. Everything feels good. We're going to go ahead and test cranial nerve number 8, which is the vestibulocochlear nerve. So I'm just going to whisper a word, and if you can tell me what I'm saying, okay?
55,
Good.
66,
Perfect. Next, we're going to move on with the Weber and Rhine test. If you'll just tell me if you can feel this on both sides, we're just going to check for lateralization.
yes.
Okay. We're going to move on to the Rhine test, which is a bone conduction and air conduction test. It should be a 2-to-1, so we'll see. Will you tell me when you can no longer hear this?
Okay.
Or feel it, I'm sorry, when you can no longer hear it.
Okay.
Perfect. We're going to look at the tympanic membrane in the ear, just making sure that it's not red or bulging, which could show a sign of infection. We're going to lift up and back on the ear. Everything looks good. That looks good as well. All right, now we're going to go to the nose. Again, just looking for any, just checking the nares. We're going to make sure that they look nice and pink and moist, making sure that there's no polyps inside the nose. If you can just look up for me. Nice and pink, everything looks good. We're going to test the patency of the nares. Can you take a deep breath in? Perfect. One more. Good. Okay, now we're going to move on to cranial nerve number 1, which is the olfactory nerve. We're just going to test his sense of smell. If you can close your eyes and tell me what you smell.
Alcohol.
Again?
Alcohol.
Perfect. Now we're going to move down, we're going to test the facial nerve, which is cranial nerve number 7. Can you puff your cheeks out? Smile. Perfect. Okay, we're going to move down to the mouth. We're just noting that the lips are pink, making sure that, you know, they're not blue. We're going to go ahead and have the patient stick his tongue out. I'm just going to inspect the inside of the mouth, looking for any ulcers, checking the mucous membranes just to make sure they're nice and pink. I'm looking at the hard and soft palate. We're going to go ahead and assess cranial nerve number 9, the gag reflex, which is intact. That's cranial nerve number 9, the glossopharyngeal nerve. We're going to go ahead and have the patient stick his tongue out and say "ah" to assess cranial nerve number 10, which is the vagus nerve. Looking for uvula, making sure that it's midline, it's not deviating to one side or the other. I'm going to go ahead and have the patient stick his tongue out and move it side to side. That's testing cranial nerve number 12, the hypoglossal nerve. Can you lift your tongue up? I'm just looking for vascularization. Again, making sure that there's no ulcers in the mouth. Also, checking at the teeth to make sure that there's none broken off, that the gums look nice and healthy, and everything looks good. While we're here, we're going to go ahead and test our final cranial nerve, which is cranial nerve number 11, the accessory nerve. So I'm going to push down on your shoulders and you push up, okay? Great. All right, now we're going to test the range of motion of the neck. I'm going to have you touch your right ear to your right shoulder. Repeat on the other side, and then down and up. Great. All right, now we're going to test the strength of the neck. I'm going to put my hand on your face. Try to turn against it, okay? Perfect. Great. Now we're going to move on and check the lymph nodes. We're going to check the auricle, post-auricle, submandibular, submental, cervical, post-cervical, supraclavicular, and the axillary. Just noting for any nodes or tenderness, which he didn't have any noted. We're going to go ahead look and make sure that the trachea is midline. We're going to go ahead and assess the carotid arteries, doing one at a time on each side, just making sure that they're 2+. Now we're going to auscultate, just looking for any whooshing noises or any bruise. If you'll take a deep breath in, hold it, and then I'm going to listen, okay? Tell me when you're ready.
Right.
Okay, deep breath in, out, and hold. Okay, we're going to do the same thing on the other side. In, out, and hold. Great. Okay, there were no bruise or whooshing sounds noted. I'm going to go ahead and check the patient's thyroid just to make sure that there's no nodules or enlargements or tenderness. You can go ahead and swallow. Okay, good. Everything felt good. Now we're going to go ahead and have the patient turn. We're going to assess his posterior chest. If you can turn your back that way. First of all, we're just gonna assess the chest just to make sure that it has an even chest rise and fall. So I'm gonna place my hands here and ask the patient to take a deep breath in and out. Okay, just checking to make sure that it is symmetrical on both sides. Next, we're gonna go ahead and assess. Can you turn just one please? Thank you. And assess for costiovertebral angle tenderness, CVA tenderness. Can you tell me if you have any pain here?
No.
Here?
No.
Perfect. Okay, next we're going to test for tactile firmatitis. I'm just going to have you say 99.
99. 99. 99. 99.
Great. While we have the patient here, we're going to check for diaphragmatic excursion. So I'm going to have you take a deep breath in and hold it. Tell me when you're ready. Okay, good. Okay, you can let it out. We're going to do the same thing, but this time we're going to take a deep breath in, let it out, and hold it. We're just assessing for any signs of when we get to dullness. Okay, and we would measure between those two areas. Okay, now we're just going to percuss the posterior chest. I'm just observing for any sounds of dullness, which might mean that there is fluid, areas of fluid. We do want to just check and make sure that the sounds are resonant. Great. Now we're going to go ahead and we're going to auscultate the lung sounds. Just listen for any crackles, wheezing, rhonchi that's noted. I'm going to have you take some deep breaths. Breathe in. Perfect. No abnormal sounds were observed. So now we're going to go ahead and have the patient turn so that we can assess his anterior chest. Okay, first of all, we're just noting that there's symmetrical chest rise and fall. When he breathes, he's not using his accessory muscles to breathe. I'm going to go ahead and look and just assess the AP just to make sure that there's no barreled chest, which is sometimes apparent in COPD, that everything looks good. I'm just going to assess for any thrills with the ball of my hand and the pad of my fingers. While I'm here, I'm going to go ahead and assess for the point of maximum intensity, which on him it's very easy to find. Next, I'm going to go ahead and percuss the anterior chest. Next, we're going to go ahead and we're going to listen to the lung sounds on the interior chest now. If you'll just take some breaths for me. While I'm here, I'm also gonna check for lung sounds on the lateral sides. Great, everything sounds normal. Now we're gonna move on to oscillating the sounds of the heart. We're just gonna make sure that we have a strong S1 and S2 sound. First of all, we're gonna auscultate the aortic valve, which is the second intercostal space right of the sternal border. The pulmonic valve, which is the second intercostal space on the left side of the sternal border. We're going to do the third intercostal space of the left sternal border, the fourth intercostal space of the left sternal border, which is the tricuspid, and then we're going to go down to the fifth mid-clavicular line, which is the apex or the mitral. We're going to have the patient lean forward just a little bit so that brings that apex to the interior chest area there. You can just breathe normal. There were no murmurs observed. He has a very regular heartbeat. Again, I'm going to have him lean forward. It's just going to bring that apex of the chest up so that I can assess for any murmurs. I'm going to assess from the base of the apex to the bottom using my bell. Okay, everything sounds good. Next, I'm going to have the patient lean back at 30 degrees. We're going to assess for the jugular vein. I'm going to have the patient look to the left. Turn your head to the left. I'm going to use a centimeter ruler and put it on the sternal angle. And then I have an index card that I'm just going to place here at the highest meniscus of the jugular vein, just to check what that is. His is normal because it is supposed to be 2 to 3. While I have the patient laying back here, I'm going to go ahead and have him lie completely flat on his back. Put that over your head. Now we're just going to assess his abdomen. I'm going to move this here a little bit. Okay, we're just going to be assessing the abdomen. First of all, I'm just going to look over the abdomen. I'm just checking for any abnormal pulsations. I'm looking for any bruising. Everything looks really good. Again, he has that even chest rise and fall. His abdomen is rounded, which is normal. I'm going to go ahead and while he's here, I'm going to listen to all 4 quadrants of the abdomen, just checking for bowel sounds. He does have active bowel sounds. While I'm here, I'm going to go ahead and listen to the aorta and the aorta and also the femoral arteries. No whooshing or bruise were observed. Next, we're going to percuss the abdomen. We're going to percuss for the liver border. We're going to start at the umbilicus and percuss up. Can I have you take a deep breath and just let it out and relax it? There we go. And then we're going to start at the mid-clavicular line, just under the nipple, and go down to assess for the, to continue to assess for the liver border. And then I would just measure those two areas. While we're here, we're going to go ahead and percuss the spleen. Just checking for any enlargements. Now we're going to palpate the abdomen. We're just looking for any signs of tenderness, any masses that we might note. Now I'm going to place my hand under the patient's back, have him take a deep breath in and relax. I'm going to palpate for the liver. It's nice and smooth. I'm now going to palpate for the spleen in the same way. And I'm unable to obtain a palpation on the spleen, which is normal. While he's here, we're going to go ahead and palpate for the kidneys, just any masses or tenderness. Okay, none is noted on either side. While we have the patient laying down here, you can go ahead and cover up. I'm going to move this back over here so we can check his range of motion in the legs. Again, throughout this exam, I'm just looking for even hair distribution throughout the body. We're going to go ahead and have the patient extend this leg. And we're going to have him dorsiflex it. Flex. Do you have any pain? Okay, we're going to do the same thing on the other side. Raise the leg, dorsiflex. Okay, no pain. While we're here, we're going to go ahead and check the range of motion of the hips on each side. We're going to have you flex your knee, bring it up. Flexion, extension, abduction, adduction. We're also going to check for internal and external rotation. If you'll bend your knee and move your hip this way. Internal and external rotation. No pain was noted. We're going to do the same thing on his left leg. We're going to do flexion, extension, abduction, adduction, internal rotation, and external rotation. We're also going to check the knees while we're here. We're going to check for any signs of the knees hyperextending. We're going to do flexion or expansion, flexion, internal rotation, external rotation. Very good. We'll do the same with the left leg. Flexion, extension, internal rotation, external rotation. Great. While we're down here, we are going to go ahead and do the ankles. We're just going to check the range of motion and strength of the ankles. So I want you to pull your feet, your toes up, and don't let me push them down. Ready? Go. Great. All right, everything is good. With that, we're going to go ahead and have the patient set up. we're gonna go ahead and continue with the range of motion. We're gonna check the range of motion in the elbows. Bend your elbows and don't let me pull them down, okay? Right, that's great. We're gonna have them extend all the way out. Perfect. Okay, now we're gonna, we can rest them. Now we're gonna check the range of motion in the shoulders. So we're gonna do abduction, adduction, external rotation, and internal rotation. Okay, perfect. Everything is good with that. We're gonna move on. We've already checked some of the arteries, but we're gonna go ahead and just work our way down to check the rest. We're gonna do the brachial arteries. Again, checking just to make sure that it's 2+. We're gonna check the radial, making sure that they're even in 2+. Popliteal, we're gonna check with both hands. The dorsal tibula. And then we're also going to check the dorsal pedius while we're down here. Okay. Next, we're going to check the patient's reflexes. Okay, we're going to do the tricep reflex. If you'll just bend your arm up and just rest it in my hand. Okay, the same on this one. You can put that. All right, we're going to go ahead to the brachial reflex. Next, we're going to do the popliteal reflex. And then the Achilles. All right. Next, we're going to check some cerebellar function on the patient. We're going to have him close his eyes and hold his hand out. And the finger that I touch, I need you to touch your nose with that finger, okay? We'll do it one more time. Perfect. Okay. We're also going to do that with his feet. We're going to check the proprioception of them. So if you'll just look straight ahead, and when you tell me if I moved your toes up or down.
Up. Down.
Perfect. We're also now going to check the stereognosis. We're going to have patient close his eyes. I'm going to place an object in his hand, and he's going to tell me what it is. Can you hold your hand out? Close your hand.
Key.
Yes. Okay, with your eyes closed, we're also going to do number recognition. So can you tell me what number I've put in your hand?
8.
Very good. Okay, we're now going to have the patient open up his hands, close them, just checking the strength of his hands. Can you squeeze my fingers? Just checking for any ataxia, just making sure that it's all equal on both sides. Okay, that's good. All right, now we're going to have the patient pronate and supinate his hands. You can just, this and then this way on your lap. Do it. Can you go fast? Very good. All right. Now we're going to move on. We're going to have the patient stand up. We're going to do the Romberg test on him. Okay, maybe just turn this way. Okay, are you touching anything? No? Okay, can you just close your eyes while you're standing there straight? Okay, perfect. All right, you can open your eyes. That was a Romberg test. We're just testing to make sure that he doesn't lose his balance. Next, we're going to have the patient do some tandem walking, which, can you just walk that way with like heel to toe, just your heels and toes, like you're walking around. Perfect. He does great with that. Okay, next we're just going to have the patient bend forward and touch his toes as much as he's able to do. I'm just checking his spine, just making sure that it's nice and straight. that there's no curvature to it. While I'm here, I'll go ahead and check the SI, just looking for any tenderness, over the vertebrae, which patient doesn't seem to have. You can go ahead and raise up some, just halfway. Again, just checking for any tenderness in that cervical area, which he does not have. Okay, you can go ahead and stand up. Now I'm going to have the patient walk on his toes and then his heels. Can you walk a little bit on your toes? Perfect, and on your heels. All right, great. Everything looks good for his test. We're actually done now with the head to toe assessment. With this patient, we also did an examination of the genitalia. He is circumcised, but we did look at the skin on the posterior and anterior surface of the penis. There was no ulcerations. We looked at the base of the penis for any inflammation or open areas. There was not any. We looked at the urethral meatus just to make sure that it was midline. To assess that, we also used a gloved thumb and index finger to squeeze, which opened up that gland just to make sure that there wasn't any discharge. The patient is circumcised. If he weren't, we would retract the foreskin just to look for any discharge, which there was none with this. The patient, of course, denied any urinary symptoms, but then we did palpate the penis with the thumb and middle finger and index finger, just looking for any induration, and there was not any. We also assessed the scrotum of the patient, did check him for a inguinal hernia, just assessed the testes just to make sure that they were firm but not hard, looked at the posterior scrotum as well, just looking for any signs of redness or any excoriated areas, which there were not any. We did assess the epididymis as well, just making sure that there was no tenderness. We assessed the spermatic cord. Everything was well. To check for the inguinal hernia, we did take a gloved hand, and with the tip of the dominant finger, we did place it on the anterior, inferior margin of the scrotum, pushed up until it was at the triangular inguinal external level, just in that little slit. Had the patient cough just to assess if there was any bulges that came out, and none were noted. For the rectal and anal exam, we had the patient lay on his left side, just assess the perianal area for any excoriation, redness, any signs of internal or external hernias. Had the patient bear down like he was having a bowel movement just to see if there was any protrusions, which there was none noted. Did take a gloved, lubricated finger, and once the sphincter relaxed, did insert it into the anus, just checking, of course, for any nodules. Went on up into the rectum, just to assess again for any nodules that might be noted. We also checked the prostate for any signs of problems with the prostate. It was rubbery like. It felt normal. Everything checked out well with this patient. So that's the end of the assessment. Thank you.